Hi everyone, welcome to Cath Lab Chronicles and Heartline. Here we discuss now a 46-year-old gentleman, smoker as a risk factor, with chest pain for almost 6 hours, ECG showing extensive interval MI, 2D echo showing severe LV dysfunction with LED territory hypokinesia. So we took patient for emergency angiogram. Angiogram suggestive of LED proximal to mid 99%. Use thrombotic load here as we can see here. Mid LED plaque and distal LED is showing 100% thrombotic occlusion here. So left circumflex artery and RCA being normal in this patient, but LED showing used thrombus burden in the proximal part and the distal part is totally occluded with the used thrombus. So patient having a severe ongoing chest pain, so we have to open the artery as soon as possible. So we have took patient for emergency angioplasty, and during angioplasty we have took the run through wire to wire the LED, and initially we have taken a step of balloon daughtering to achieve the distal flow, but we failed. So we took aspiration catheter thrombustor for thrombus aspiration. Despite of 8 to 10 rounds of thrombus aspiration and balloon dilatation, we could not achieve the flow. At the meanwhile, we have also given intracoronary tyrofeban and vasodilators like nitroglycerin and nicoran and adenosine. But initially we could achieve transient flow in the distal left anterior descending artery, but immediately again there was no flow. So at the end, despite of all efforts and multiple cycles of thrombus aspiration, we could not achieve the flow. Hence stent is not deployed, and it is not advisable also to deploy stent if distal flow is not achieved. So what's the problem here? Why we were not able to achieve the distal flow even after so much efforts? The answer is used thrombus burden in left anterior descending and microvascular thrombotic obstruction, which was not allowing for distal flow. So in the next step, so what we can do as a next step in these patients? So if you have done so much of efforts and the patient's hemodynamic is compromised, so we can insert intra-aortic IBP and IV antiplatelets like tyrofeban infusion. Other option what we can do is systemic thrombolysis if we are not able to achieve the distal flow. And third is important is intracoronary thrombolysis with thrombolytic agents. There are a variety of thrombolytic agents, non-fibrin specific and fibrin specific. So non-fibrin specific, we have streptokinase. We can inject 250,000 units intracoronary. Urokinase, we can inject 2 lakh units of urokinase. Prokinase, if available, we can inject 10 mg. With the fibrin specific, altiplase, we can start with 10 mg and we can go up to 20 mg intracoronary. Tenecteplase 4 mg pre-stenting and 4 mg post-stenting is usually indicated. Retiplase exact dose is not available, but according to recent trial, Recover 2 trial, which is published in 2022, 9 mg or 18 mg we can give intracoronary as per the trial. So how we can inject this intracoronary thrombolytic agents? We can inject these thrombolytic agents with the help of microcatheter or thrombus aspiration catheter, and we have to keep the patient in ICU for observation for 1 or 2 days, and after 1 or 2 days we have to take the patient for check CAG, and if the flow is achieved, the stenting can be done. And so in this case we have done we have given injection tyrofeban and this IBP balloon we have inserted, and after 2 days we have taken a check shoot and the distal flow is achieved. So we have done the proximal to mid thrombotic burden that has been stented with 3.5 into 36 mm stent. So patient is stable vitally and is been about to discharge today. This is how we can manage this no flow, reflow and use thrombus flow. Thank you.